frontline treatment of advanced gastric gastroesophageal cancer really now requires a personalized approach. And there are four standard of care biomarkers that every treating oncologist really needs to know before they can decide what the most appropriate regimen is for a patient. And the way I think about these is I prioritize them. I prioritize them based on their predictive ability to induce a response. And so, in order, in my practice, it begins with mismatch repair deficiency, which predicts for a very good response to immunotherapy, followed by HER2, which predicts for a good response to trastuzumab, HER2-directed antibody. And then after that is really when zolbetuximab comes into play. And that includes the claudin expression balanced with PD-L1 expression. And the GLOW trial, which of course combines zolbetuximab with capecitabine and platinum chemotherapy, and SPOTLIGHT, which combines zolbetuximab with 5-FU, FOLFOX chemotherapy, showed an improvement in progression-free and overall survival. And this was limited in patients who had tumors of claudin expression of 75% or greater. And this accounts for about 40% of all of these patients that we see, which is a significant portion. Whereas PD-L1 expression, which is predictive of response to checkpoint inhibition with PD-1 inhibitors, nivolumab and pembrolizumab, about 70 to 80% of these patients are PD-L1 of all patients with gastroesophageal adenocarcinoma are PD-L1 positive. Then about 50 to 60% of these patients are PD-L1 high. So of course, in PD-L1 negative or PD-L1 low expressing tumors that are claudin high, this now allows us to reach for an addition to chemotherapy with zolbetuximab, whereas previously patients were treated primarily with chemotherapy alone. What will become interesting as we see more, and what gives us a choice, is patients who have PD-L1 high expressing tumors and claudin high expressing tumors. And that's going to be really a conversation of the risks and the benefits of checkpoint inhibition or claudin-directed antibodies, zolbetuximab, both with the toxicities and the benefits of each. So the approval of zolbetuximab will certainly have an influence in how we treat patients with claudin high expressing tumors, primarily PD-L1 negative, mismatch repair proficient HER2 negative tumors, but even some with perhaps PD-L1 high expressing tumors who may not be a candidate for checkpoint inhibition. I think one of the biggest challenges of the real practical implementation of zolbetuximab is going to be claudin testing. And this is a new drug, has not previously been used, and that differs from the FDA approval of a drug that's used in a different situation, right? So claudin testing has not been standard practice, so may not be implemented. So getting our pathologists comfortable, getting the workflow comfortable such that right now the biomarkers that we talked about before, mismatch repair proteins, HER2, PD-L1, these are all standard of care reflexive anytime anyone gets a biopsy of a gastric or a G-junction tumor. We have those markers already, and that can inform our decision on the appropriate regimen. So first and foremost is getting claudin reflexively tested so that we know whether or not claudin expression is high enough that it would predict for a response to zolbetuximab. And I think the second, which is also critical when implementing a new drug as opposed to, like I said, a drug that's used for a separate indication now being approved for a new indication, is for the practitioners becoming comfortable with managing the side effects. And claudin-targeted agents as a whole, but zolbetuximab specifically, really have a unique side effect profile that really impacts a patient's experience. And primarily this is nausea and GI toxicity and gastritis, and how we manage that, and how oncologists and our entire team, nurses, physician's assistants, nurse practitioners, become comfortable managing this is really going to influence its implementation into the community. The factors that inform my ultimate decision, or the decision I make with, in collaboration with the patient sitting in front of me on what regimen is best, is I talk about what are the potential benefits and the magnitude of that benefit. So we know that zolbetuximab can prolong progression-free and overall survival compared to chemotherapy alone. One thing that unfortunately wasn't shown in these trials is that it didn't improve response rates beyond what chemotherapy can do alone. So that's important, especially when these patients present with really symptomatic disease, large tumor burden, and it's important to improve their quality of life to get rapid tumor regression. That we're going to see with the chemotherapy alone, and there's nothing additional to it added to that with the addition of zolbetuximab. So that plays a role. The other side of the coin is the side effect profile and what toxicities we can expect, and if the benefit is outweighs the side effect, and what patients are willing to tolerate, and how we learn to manage this better, the side effects of this new drug. I think this is a really exciting approval because zolbetuximab is first in class, but I think what's even more exciting is what's to come. And that's really twofold. First is claudin as a target. And zolbetuximab, like we said, is first in class, meaning that newer generation of antibodies are more specific for the claudin 18.2, more efficacious, and with a better side effect profile. And then add to that bispecific antibodies that are T-cell engagers or antibody drug conjugates with a cytotoxic payload that can be more efficacious. So with better drugs, then perhaps claudin expression, which now is the cutoff is 75%, can even become lower to include more patients to benefit from these types of drugs. And number two, the HER2 story was really important in showing us that there is synergy between antibody treatments and immunotherapy treatments. Now, HER2, of course, is an oncogenic driver for this disease, whereas claudin is a tight junction protein that through carcinogenesis becomes expressed on the surface of gastric cancer cells. So it itself is not driving the process, but it is a target, an area of vulnerability. So whether or not combination of claudin-targeted drugs with immunotherapy is synergistic or purely additive remains to be seen, but those studies are ongoing, and I think it's a really exciting area of development.